Good afternoon, everybody. Welcome to my presentation about my PhD topic, the Diagnostics of Pancreatic Neoplasms. So, pancreatic cancer has the third highest mortality rate among malignant diseases, with a 5-year survival rate below 10%, and many cases diagnosed too late for curative treatment. So, there is an unmet need for faster and highly accurate supplementary diagnostic tools, such as rapid and macroscopic on-site evaluation. Our systematic review and meta-analysis shows that incorporating these techniques in routine sampling can increase diagnostic sensitivity significantly by 7% in case of ROSE and 5% with MOSE. So routine implementation of these techniques should be considered during the sampling of pancreatic lesions. And unfortunately, there is a need for more high-quality, large-scale randomized trials to understand whether its on-site evaluation techniques are better than each other, and policymakers should allocate some funds to expand access to these on-site evaluation techniques. My name is Zoltán Bánfalvi. I'm an internal medicine resident and a PhD student in the Institute of Pancreatic Diseases, and our vision is that patients with suspected pancreatic cancer should be diagnosed as early and efficiently as possible. Therefore, our mission is to identify the most reliable and accurate diagnostic methods. Currently, we have 2 ongoing projects. The first one about this on-site evaluation techniques in the sampling of pancreatic cancer, and we are using the methodology of a systematic review and meta-analysis. Our second project will be a protocol for a randomized trial regarding to Splanchnic vein thrombosis in acute pancreatitis. So the first project titled Comparing the Diagnostic Accuracy of EUS-FNB to On-Site Evaluations in the Diagnostics of Pancreatic Neoplasias. Pancreatic cancer has a third highest mortality, and the time is the most important factor regarding to it, because previously resectable cancer can easily progress to an irresectable state. EUS-guided fine needle biopsy is the main diagnostic tool. It has a high sensitivity and specificity on its own, but the problem still the success rate of tissue acquisition. So there is 2 supplementary techniques developed. The first one is ROSE, rapid on-site evaluation, which is done by an experienced cytopathologist in the endoscopic room with expensive equipment. Other one is MOSE, which is the macroscopic on-site evaluation, which is done by the endosonographist by its eyes. Our aim is to identify the methods to acquire the adequate sample as soon as possible. Our clinical question is that do MOSE and or ROSE improve the success rate of tissue acquisition compared to standalone EUS-FNB? The population is patients with suspected pancreatic cancer. Index test is ROSE, MOSE, or ROSE and MOSE combined. The reference test is the histopathological result, and we are looking to diagnostic accuracy regarding to pancreatic cancer. Our hypothesis was that MOSE and ROSE can improve the success rate, therefore allowing for a better diagnostic accuracy compared to standalone EUS-FNB. We conducted a systematic search in 5 different databases last October. After the selection process, we identified 42 eligible articles for the project. So this is the first figure for sensitivity, also known as true positive rate. For the ROSE group, we have 7 studies with 1,000 events. For MOSE, we have 16 studies with 1,600 events. And for standalone FNB, we have 9 studies for 1,400 events. Heterogeneity is rather high in each group because there is a lot of different locations of the cancer, different needles they used, and different demographical data in the populations. But we found that standalone FNB has a poor sensitivity of 0.88 or 88%, while ROSE has 95% sensitivity, which is statistically significantly higher. In case of MOSE versus standalone FNB, the sensitivity of MOSE is 93%, also statistically significant, which is both techniques show statistical significance higher sensitivity, which is clinically highly important. From the multivariate meta-analysis model, we would be able to compare ROSE to MOSE, and the analysis showed that there is no significant difference in case of sensitivity between ROSE and MOSE, which is also very clinically important. In case of specificity, there were, or true negative rates, there were 80 events in the ROSE group, 180 in the MOSE group, and 227 in the standalone FNB group. The heterogeneity also high from the same reasons, and we found that In case of specificity, there was no significant difference between FNB and ROSE and MOSE. FNB only had a 92% specificity, ROSE has a 94% specificity, and MOSE had a 90% specificity. There were no significant difference. In case of ROSE versus MOSE, there were also no significant difference between specificity. The last outcome we assessed is sample adequacy, which is the ratio of the histologically adequate samples from all samples. In the ROSE population, there were 700 events. In the MOSE population, there were 1,200, and in the standalone FNB, there was 1,000 events. And as you can see on the figure, sample adequacy was same, 96% in all of the groups, with slightly different confidence intervals, but there was no statistical significant difference in this analysis. So as all study, this study has its own strengths and limitations. Strengths are the relatively large patient number in each method, and this project includes and evaluates both ROSE and MOSE. The limitation is, unfortunately, there was not only RCTs involved, so different study types were assessed, and unfortunately, articles usually don't report all of the examined outcomes. For the conclusions, that on-site evaluation techniques can increase the sensitivity of EUS-FNB, and there is no need for expensive equipment for higher diagnostic accuracy. Yes. The implication for practice is that the recommendation can expand with details of these on-site evaluation techniques, and for research, there is an urgent need for design-specific RCTs for ROSE versus MOSE to understand it more, and maybe to establish a US registry for further investigations. Currently, the risk of bias assessment and the grade assessment is done, and we are in the end of the manuscript writing phase. The title of the second project is investigating the effectiveness of DOAC and LWMH therapies in the treatment of Splanchnic venous thrombosis in acute pancreatitis patients after discharge. It will be a study protocol for a multicentered randomized non-inferiority trial. So acute pancreatitis has an incidence of around 30 cases per 100,000 people, and the mortality up to 30% in severe cases. There is several local complications regarding to AP, for example, Splanchnic venous thrombosis, which has an incidence of around 20% in all acute pancreatitis cases. It can lead to portal hypertension, which can cause variceal bleeding, which is a very severe condition. The main diagnostic technique of Splanchnic VT is contrast-enhanced CT scans. Sometimes color Doppler transabdominal ultrasound can be used, and in a few selected cases, endoscopic ultrasound can help too. The ISTH guideline currently recommends early anticoagulant treatment, but DOAC therapies are off-label in most countries for this indication. Our aim is to determine the most effective method of anticoagulant therapy in this Splanchnic venous thrombosis. The clinical question is that the use of direct oral anticoagulants is as effective as LWMH in treating pancreatitis-related Splanchnic VT after hospital discharge. Population will be AP patients with Splanchnic venous thrombosis at discharge. Intervention is direct oral anticoagulant therapy. Comparator is LWMH, and the primary outcome will be the recanalization rate at 3rd month control. Secondary outcomes will include recanalization time, incidence of rethrombosis, bleeding, mortality, quality of life. Our hypothesis is that these DOAC therapies are non-inferior to LWMH in the treatment of pancreatitis-related Splanchnic VT. Clinical implication is that if there is a parallel alternative treatment that can increase the patient compliance, allowing for a quicker recovery for them. In the quick summary in the end, the first project about different diagnostic techniques in pancreatic cancer, the planned submission date is this September. For the second project about different anticoagulant methods in pancreatitis-related Splanchnic venous thrombosis, the planned submission date is next June. In the end, I would like to thank you with a quote from Neil deGrasse Tyson that the good thing about science is that it's true whether or not you believe in it. Thank you.
Thank you very much for the presentation. Now these two topics are open for discussion. Anybody?
Thank you for the congratulations for the nice project. Regarding your first topic, could you subgroup for needle sizes regarding Rose and Mohs?
That was the plan, but unfortunately there is not enough data about different needle sizes. Only for, one sec, diagnostic accuracy about Mohs. It's not a comparative, but just a pooled that show that in case of Mohs, the 22G needles are better significantly in diagnostic accuracy, but in the other groups, there is not enough data regarding to the needles to have this analysis.
Okay, thank you.
For this question, calm, this is in the guideline. The guideline says the 22 new generation FNB needle is recommended based on the guideline. That means we have a clear answer for this.
Have you excluded cytology from the project?
What do you mean, like
Rose and Mohs of cytology at all?
It's the bioptic sample, so it's always
FNB.
Yes, it's the sensitivity of the histological sample acquired with Rose or without Rose.
Okay. Next question. So between the naked eye and the microscope, there's also the magnifying glass.
Yeah.
Is there any Mohs study reported with the use of a magnifying glass, like 2 times, 3 times? Because that's cheap. You can't argue that.
Yes, in one study they used a stereo microscope with 5 times magnifying, and they measured the sample with that. So not just by a regular ruler, but under a 5-time magnifying glass.
Thank you.
But you would not expect much difference between the Mohs and magnified Mohs, since looks like from your data that it as valuable as the Rose, the rapid on-site cytology assessment. So you don't need to magnify if you are seeing those white particles in the sample. You are okay with that.
Yeah.
Also, an important question of how many times you need to puncture the lesion. Was it a standard in the articles, or was there any variance in them?
It was different, but the studies reported the needle punctures they used differently. Sometimes means, sometimes median, sometimes just the range, but usually it was 2 or 3 punctures. The guideline also said at least 2.
So diagnostic adequacy means that you have got, not you, but a pathologist has enough tissue to look at and assess.
The sample adequacy. Yeah.
So that's one thing. And diagnostically, a specimen is adequate if it's reported as pancreatic tissue, although I suspected pancreatic cancer. So diagnostic adequacy is not exactly diagnostic accuracy. No. Is that different between the 2 methods? So, like I do 100 EUS-FNB with Rose, and I do the same number of EUS-FNBs with Mohs. Do I get from the same population the same rate of pancreatic cancer reported eventually?
Because the sensitivity, the true positive rate is kind of not different, then it should. You should have.
So the beauty of the Rose is that it does tell you that the sample is tissue, but it can also tell you it's tissue from the cancer. Yeah. And I don't think that most can do that. And I think that would be interesting to see if you're looking at the diagnostic accuracy, not adequacy. Because if the diagnostic accuracy is better of Rose than Mohs, then Rose should be superior to Mohs.
We can see.